Propofol for migraine. Who's used Propofol for treating migraine? who Michael Jackson, yeah. That's for sleep disorder that was used for. No. Migraine, it actually does work for migraine, but in a special select group. So migraine sufferers, who suffers from migraine in this group? Right, go on now. That's alcohol-related migraine. So who gets intractable, severe migraine sometimes that lasts for days? Does any of you, the group, get it? Yeah. So you know how bad it can be when you get it. And these patients come into the emergency department and they've tried everything, okay? They've done everything they can, but they can't get rid of this migraine headache, and it's severe. And look, what do you do in the emergency department? It's too late to give them all those things you can give them beforehand. You're not going to give them morphine because you get those rebound headaches with morphine again. What do you do? You usually pump them full of a few litres of fluid, give them some Largactil, put them to sleep somewhere, okay? That's what happened. They wake up and you go, how do you feel now? And they're like this, right? And you say, how's the migraine? Oh, 5 out of 10. Well, that's great. Go home and have a good sleep. And you know, and they're like this. And you know, oh, how are you going to get home? I'm driving. Okay. All right, so I don't think sometimes that we treat these patients. I think we kind of do something and we feel good about it and we send them home and they're not quite treated well. I used to have another strategy, 6 Aspalgin I used to give them. I used to give them a couple of Panadeine Forte, some Indesid, PR. I don't know why I gave them to them PR, I just made me feel better about doing something. I give them 100 milligrams and they'd say, can I get it orally? You know, but I don't know and I don't feel good about it. And then I read some papers and of course, you know, when the student is ready, the master will appear, they say. And this patient walked in and I thought, experimentation time. No, I thought, let us start my new series, my new study. And with this lady, I now have N equals 1 patient in my study. Right? But the effects were so dramatic that it was worth doing it, okay? But the reason I only have N equals 1 is because you can only do it on a select group of patients. You can't just willy-nilly do it on everybody. And the other thing you don't want to do is you don't want to be known for the person that gives Propofol for headaches because people are going to come in looking for it, okay? So you've got to be a bit careful about that. So she's had headaches for days. You know, she's had all the Aspalgin, the Panadeine Forte in the world, the Naproxen, everything. She's tried everything. Won't go away. So I'm going to give her, when she comes in, a litre of fluid, some Maxilon, and I'm going to put her on the Largactil, and then we'll see what happens. All right. And this is what happens. We haven't really treated it. So a 58-year-old woman, headache for 2 weeks, tried everything she possibly can. She came into the ED the previous night, and we sedated her with Largactil, and we sent her home. Okay? Pain is now 6, or is it? It was 6, now it's 9 again. It's gone back up. She's rebounded up, and Propofol's given to her. And this is the way it's been given to her. So she gets 20 milligrams, so, 2 mils of Propofol over periods of time, and this is what happens to her score. Pain score 9, 10, down to 1. She gets a total of 110 milligrams. What was the evidence? The evidence was Cruz is a sort of pain anaesthetic specialist, and he noticed that patients that had an improved headache when they got Propofol in preparation for epidurals. So he did a study on it, and he actually found that there was some evidence for this. Study in anaesthesiology, other studies showed hemicranial headaches did better, but these were severe headaches, intractable headaches, and they did better when they were given Propofol. We don't know the mechanism. Okay? We don't know why it worked on these patients. And most of the studies were 20 milligrams of propofol given at 5-minute intervals to a maximum of about 120, 110 milligrams. And the pain scores went down. Some of these patients went home with a pain score of 1, which is pretty good. Okay? When I did it on this patient, and this is the problem with it, right? When I give Largactil, I've given Largactil and that patient's in the emergency department for how long? 4 hours or 5 hours or 6 hours or whatever. I can give Propofol, but at these small doses, people say, oh, you don't need a resus cure. Well, damn straight you do. You need to put them in resus, monitor them up. This is a sedation procedure, but you're giving tiny little doses of Propofol. It does take a senior person that's airway capable off the floor for a period of 20 minutes or so. But what's the difference between Propofol and using something like that? In Propofol, it turns off, okay? So if I'm doing this for 20 minutes and a pain score is 1 out of 10, Propofol's done. I can walk out. At no time is she sedated where she's asleep. And when I was doing this, it gave her a little bit and gave her a little bit, and she went 9, and I went down to sort of 10. At 6, she went, oh, that feels really good. Right? She was getting some sort of euphoric element from it. And it kept going down. Now, I will admit, in the studies there were very few episodes of hypotension. She got a little bit hypotensive. She got a bit of fluid in, and I gave her a tiny little trickle of metaraminol at one time. But she went down to, it was a 1 or very close to a 1. She got some Panadeine Forte, and she went home. And she went home soon after we finished the procedure. Okay, but this was a special select group. So you don't come, I've got a bit of a migraine, put you in resus. So this is somebody that tried for a week, tried everything, can't get rid of it, jackhammers in the head, a little bit of Propofol, small doses, headache went. Something to consider. The same guy that did these studies has now started looking at the wonder drug ketamine. Crutes as well. So 247 people, now it was an open label study. People knew what they were giving. And they gave ketamine at smallish doses of 0.25 to 3 milligrams. They were trying not to get dissociative states, but just use ketamine for analgesia. And certainly ketamine has been used like this before. The Alfred did a study here in Melbourne where they were giving 10 milligrams of ketamine to patients that had trauma, and it really reduced the pain significantly. Okay, so they used ketamine. They had infusion times there. Total dose of ketamine was about 100 milligrams. It was significant, but about 1.2, 1.3 milligrams per kilogram. These patients had scores reduced down to 2 out of 10. So they're using different things. Propofol's been used quite a few times. It's in the literature. You should look this up. There was a blog written on this. I think I've given you a copy of the blog with the literature references in there. But it is for a select group of patients. You have to monitor them. You have to do airway precautions, everything. But you're clear and easy in about 20 minutes with these patients. And that's really important. Select group of patients, though, they have to have tried most things. Propofol versus ketamine, why do I like it? Because ketamine, if you do dissociate them, it takes a while for them to wake up. So you've got to watch them for a while. Whereas Propofol, I was talking to her, how are you feeling? I feel pretty good now. I feel good. I feel much better now. Okay? At no point was she asleep. At no point was there any issue with breathing. And then it turns off. You're done. Okay? She can go. She can go 15 minutes later. If the headache is better, go home and sleep it off. I think it's something to consider in this special select group. Read the paper, read the blog in there. I think it's an important adjunct to your management. Okay, any questions on that? Yes. Can we get a mic out, please? Because I have bad hearing. You'll have to scream. No, not screaming enough for me, sorry. Mic up.
In your extensive patient series there, did the patient have any rebound?
No. Well, in those cases, no rebound. Okay? In those patients in those studies, no rebound. I mean, I only had one patient that I did it on, and she went home. She had a rebound on the Largactil, but certainly nothing that I knew on that. And none of the studies showed that they had rebound effect, like you'd get with morphine, for example, because it's a different receptor mechanism. Yes? Can you turn this mic on, please? Talk. Keep talking. Is anybody in the booth? No? All right,
Yeah,
keep
they're
talking
on
then, that's fine. I'll walk down to you so I can hear, because I can't hear. Oh yeah, you on? Yeah, keep going, tell me.
Propofol is being used for migraine by some of the guys where I work.
Yep.
I have been in a position of being on when a couple of these people come back within 3 days saying that their headache's back and they really like that Propofol stuff and they like that.
That's one of the dangers of it. People, so the comment was they've come back 3 days later having a rebound headache and they've liked the Propofol. Can I have it again, please? Yeah?
I think we need to consider if we're having this as an option,
Yeah.
how often we're willing to give
Yeah.
anaesthetic.
See, yeah, I think that's a good point. How often are you willing to give it? I would only give it once per patient. I wouldn't be, if you came in 2 days later and you said, I've got a rebound headache, then I wouldn't give it to you again. But if you came back a month later or 2 months later and it worked really well for you the first time, I'd consider giving it to you again. Only after you've tried most things though. Wouldn't give it to you as my first port of call. I'd still treat you with the other stuff that I treat you with and make sure I can get rid of the headache. But I think that's a good point. We don't want to get in the situation where we're attracting people to come back wanting Propofol or wanting ketamine or, because that's not the business we're in. Although, we give morphine for a lot of back pain, that's the business we're in. Okay, and we're not there to judge them, we're there to treat them, but I take your point, Mel. Yes, sir.
My question concerns paracoxib, my favourite analgesic drug. Great in migraine, great in back pain. Works really well. Have you tried it?
No.
Give it a go.
What's the drug?
Paracoxib, Dynasty.
Yep, and how much do you give?
40 milligrams IV or IM.
40 IM or IV. And do they get rebound from that?
And that lasts for 12, 24 hours. Seems to be really effective. Almost side effect free. Must have got ring phase.
Okay, and for migraines? Okay, well that's something to think about. Okay.
Okay, are there any more questions for Peter?